Thank you very much for the introduction, and thank you very much for the invitation, because it's a great pleasure for me to be here with you. And I would like to give some highlight about the subject in the title of our presentation. There is no disclosure. All of us know that under the combined combination of different predisposing factors, such as genetic predisposition, hormonal factor, together with environmental factors, an autoimmune process starts, and after that, serological positivity and clinical symptoms occur. And sometimes these combination can be sufficient for the diagnosis of a definite connective tissue disease, and we treat the patient as this diagnosis. But the majority of the patient does not evolve further, and we see the undifferentiated stadium, and it can be stable for years and years. And one part of the patient will evolve further, and these patients are so-called at risk for some special connective tissue disease, and further progression will make the development of an early or pre-connective tissue disease, after all, the definite connective tissue disease. And we see that two or more connective tissue disease can overlap with each other also. What we know about the undifferentiated situation or state? We know that 50% of systemic autoimmune disease at onset have an undifferentiated profile. Most of the patients are females in the third or fourth decade of their life, and up to 40% of UCTD patients evolve into definite connective tissue disease during follow-up within the first 3 or 5 years from the initial diagnosis, and more or less 60% remain stable. What to do with these patients? The stable UCTD is a distinct clinical entity with peculiar clinical findings, and we know that we have no definite classification criteria for UCTD exist. The 3 main parameters which called the classification criteria for UCTD could be at least one clinical manifestation of CTD, positive antinuclear antibody with 2 measurements, and the disease duration of at least 3 years. The main clinical features of UCTD could be the Raynaud syndrome, the unexplained non-erosive symmetric polyarthritis, and keratoconjunctivitis sicca. Of course, together with this, we have additional symptoms such as arthralgia, rash, or some other kind of dermatitis, interstitial lung disease, and we have to stop here because the so-called interstitial pneumonia with autoimmune features, the IPEF, could be an undifferentiated situation for the patient, and it's one part of the undifferentiated connective tissue diseases. Dysphagia, pyrosis, esophageal dysmotility, cardiac manifestation, pleurisy, pericarditis, unexplained peripheral neuropathy or central nervous system symptoms, puffy fingers can be the first signs of the UCTD symptoms, elevated inflammatory markers which cannot be explained by anything else, and abnormal capillary pattern. If we see the stable UCTD, which is stable for years, the clinical manifestation of stable undifferentiated connective tissue disease could be and the frequency of the symptoms is the highest with arthralgia, arthritis, and Raynaud phenomenon together with the positive antinuclear antibody. But what is the most important thing to collect and elevate that patients who will evolve in the follow-up period, because we have to start and notice immediately these patients and start the treatment to prevent the damage of the patient. In the recent decades, there were several articles published according the UCTD subject, and these results were different according to the patient selection and according to the definition of UCTD. The final publication showed some results. It involved 6 UCTD cohorts, more than 1,100 subjects who were classified as UCTD at baseline data. And the results showed that 28% of the patients have an evolving course, with the majority developing SLE or rheumatoid arthritis, or the third one was Sjögren's syndrome within 5 to 6 years of the UCTD diagnosis. And 13% of the patients achieved remission. Let's see further. What about the frequent clinical manifestation of UCTD was at the diagnosis? You see on the bottom of the slide the Raynaud's, the arthralgias, arthritis, which was similar to the results of Professor Mosca from 2006. So nothing changed from that time. We have to collect the patients with Raynaud's, arthralgia, arthritis, and the other symptoms, such as oral ulcer, alopecia, photosensitivity, occurred less frequent, and the real less frequent symptoms was fever, malar rash, subacute cutaneous LE, livedo-reticularis sclerodactyly, myositis, and central nervous system symptoms, which was less than 2% of the patient population. What about the immunological parameters? You see that the highest frequency was shown with anti-nuclear antibody. The second one was the anti-RO antibody, and the third one was anti-RNP antibody. The others occurred less frequently. Why is it so important to focus on the evolving patient? Because the time between the onset of the symptoms and the moment of diagnosis is critical for planning follow-up, as the long-term outcomes and prognosis differ between these diseases. But do we have really good predictors for evaluation of UCTD? Maybe yes. And the aforementioned publication showed that the evolved UCTD showed special risk factors for evolving. It was the Raynaud phenomenon, the Zika syndrome, photosensitivity, polyarthritis, cytopenias, anti-nuclear antibody positivity with a higher titer than 1.160, anti-centromere antibody and anti-Rho antibody. And at the bottom of the slide, you see the odds ratio of these symptoms. The higher odds ratio was correlate with photosensitivity and polyarthritis. But let's look into the details a little bit. We know the evaluation from UCTD to SLE process. And this shows this slide. I don't want to go into the details, but from the previous mentioned publication showed that the risk factors for evolving UCTD to SLE were the younger age, the African American race, fever, photosensitivity, serositis, discoid lupus, anti-dsDNA, anti-SM, and anti-phospholipid antibodies. And there are another meta-analysis for this risk, and it showed that the real strong predictors for progression to SLE was also the younger age, the serositis, and the presence of anti-dsDNA antibody. So if we have a patient with these parameters, as UCTD patients, we have to be careful for the evolution of the disease. Of course, the risk estimation can be improved with the weighting some special parameters, and this was done by this study where more than 400 UCTD patients were involved, and after the involvement, almost 10% of the patient has high so-called SLE risk probability index, and they were diagnosed as SLE. And the probability factors was the malar lash, the thrombocytopenia, proteinuria, antinuclear positivity, and some immunological parameters typical for SLE. These parameters got the highest score. So this SLE risk probability index enable a significant proportion of patients to be identified as SLE in these UCTD cohorts. We collect the clinical and routine immunoserological parameters, but is it really have good biomarkers for evolution? Yes, we know some. We know that the evolution of antibodies from non-specific to specific antinuclear antibodies prior to SLE development can occur 9 years before the onset of the definite disease. And the preclinical SLE evolving interference signature can predate the diagnosis by 3-4 years before the definite disease. You can see here the result, the higher interference signature, which is more sensitive than anti-dsDNA, NA, and complement factors. This is the sialic acid binding Ig-like lectin-1, which is one molecule of the interferon pathway. What about the progression to systemic sclerosis? We know some risk factors towards systemic sclerosis, and this is the anti-topo antibody with real high relative risk ratio, higher than 10, anti-nuclear antibody higher than 1.320, avascular areas of the capillaroscopy pattern, and anti-centromere antibody. And finally, there is a recently published data about the U-star cohort, which shows that there are different probabilities between the different combination of symptoms or alterations occur. For example, a systemic sclerosis specific autoantibody together with puffy fingers mean the highest suspicion for evolving systemic sclerosis, and you see the different combination and frequency here. Of course, we have more and more data according the systemic sclerosis evolution by biomarkers which involve the endothelial fibrotic process or T-cell, B-cell processing factors. Here you see, but these are not in the daily practice. Maybe later we'll find some exact biomarkers which will mean that this patient is UCTD at risk for systemic sclerosis. We have some special clinical symptoms, which means that the UCTD at the risk for rheumatoid arthritis, and this is the polyarthritis and rheumatoid factor, the SICA, anti-ARO, anti-LA antibody means that the evolution will occur towards Sjögren's syndrome, and MCTD means also the polyarthritis and anti-RNP antibody. One of the most important questions for our patient, the quality of life. We could think that maybe UCTD doesn't influence the quality of life so severe manner than, for example, SLE, but this study showed that it's not true, because no significant difference between UCTD and other established CTD regarding the health-related quality of life exists according to this. We have heard about pregnancy a lot, and we know from that, I want to repeat it a little bit, that UCTD patients is more women with childbearing age, and several studies have reported an increased prevalence of adverse pregnancy outcomes in women with UCTD compared with the general population, as we heard in the previous presentation. What to know about the treatment of UCTD? The majority of patients requires less intense immunomodulatory or immunosuppressive therapy. The general therapy could be the non-steroid anti-inflammatory drugs. We commonly use hydroxychloroquine against arthritis or rashes. Low-dose glucocorticoids for a short period can be allowed, and less than a third of UCTD patients require chronic immunosuppression. If the disease progresses, we have to choose new immunosuppressive or targeted therapy according the organ manifestation and according the progression of a definite connective tissue disease. And some summary about the undifferentiated connective tissue disease. We know that about 60–65% of the patients with an undifferentiated onset will not develop a defined connective tissue disease. The evaluation to define disease occurs early in the disease history, between 3 and 5 years. In the majority of cases, within the 5 years. The clinical picture of stable UCTD generally is mild and characterized by the absence of major organ involvement, and stable UCTD should be monitored carefully during pregnancy. There are predictors for evolution of UCTD at risk for definite connective tissue disease, and because of this, a closely follow-up is required for our patients. What about the mixed connective tissue disease? Till today, it's sometimes a debate whether it's a distinct entity or not, or only the previous stage of a definite connective tissue disease. We know that mixed connective tissue disease collect different clinical symptoms from other connective tissue disease, such as systemic sclerosis, lupus, and rheumatoid arthritis, but it has a unique antibody profile, and this is the U1 RNP antibody. There are 4 classification or diagnostic criteria for mixed connective tissue disease from the recent decades, and they use similar organ involvement and clinical symptoms such as Raynaud phenomenon, edema of the hands, myositis, polyarthritis, and so on. And in Japan, there is a new classification criteria with the similar clinical symptoms of the disease from 2019. It can be used, all of them can be used. But what's the problem with the mixed connective tissue disease? We know that if we have patients who are referred to us with mixed connective tissue disease, we are not sure that it's really that or not. This is evaluation involving 85 patients referred as MCTD, and only 1/3 of the patients fulfilled the diagnostic criteria for MCTD. And from 33 patients, 76% fulfilled the classification criteria of at least one other CTD addition to MCTD. And it was SLE, rheumatoid arthritis, and myositis. And immunomodulation was required more or less half of the patients, and only 11% was not immunomodulation. So we have to say that a high risk for misdiagnosis for patients with MCTD we face. As a multi-organ disease, MCTD required prolonged immunomodulatory therapy to achieve remission. There is another study involving 147 patients with MCTD, and you see that almost 10% will evolve further, which was ankylosing spondylitis, systemic sclerosis, rheumatoid arthritis, and lupus. From this cohort, Puffy Hands predicted a stable MCTD phenotype on univariable regression analysis, and there were 13 patients, 13% of the patients remain in remission in the whole observation period. The strongest predictor of remission was percentage of predicted higher FVC. And MCTD in this cohort was a relatively stable disease. But let's look into the details. We have some data about the genetic background of MCTD, and some of them shows a genetic correlation with MCTD, but this is not a strong evidence yet. And we have genetic alleles which could be protective against MCTD. Of course, we require further evaluation to improve our knowledge about this subject. If we analyze the capillaroscopic pattern of MCTD patients, it is shown that the presence of this scleroderma-like pattern and reduced number of capillaries seems the most typical capillary patterns in MCTD in comparison to UCTD patients. So MCTD is different from UCTD in this cohort. And this is the French Pulmonary Hypertension Registry, according to the internal organ manifestation of MCTD, where MCTD with PAH and without, and SLE with PAH and systemic sclerosis with PAH or without was involved. 86 patients with MCTD PAH were evaluated, and pericarditis, polyarthritis, thrombocytopenia, ILD, and anti-SM antibodies were independent predictive factors for PAH associated with MCTD. And the tobacco use exposure was an independent factor which predict the mortality of MCTD patients. And in conclusion from this study was that PAH is a rare and severe complication of MCTD associated with 56% within 10-year survival. There are a special answer after immunosuppressive therapy according the Neifold capillaroscopic pattern with MCTD patient, and it was shown that the prevalence of scleroderma pattern in MCTD was higher than SLE patient and less frequent than compared to systemic sclerosis. And in MCTD, the higher prevalence of PAH in a patient with scleroderma patterns occurred. So if we see a patient with MCTD with scleroderma pattern, we have to evaluate these patients for PAH development. And after the immunosuppressive therapy, this study showed that MCTD differed from SLE and systemic sclerosis and myositis because the immunosuppressive therapy, the improvement of neifold capillaroscopy abnormalities were seen but only in MCTD patients. So after all, we can say that MCTD is real, a distinct entity which is different from UCTD and from the other connective tissue diseases. And finally, I would like to highlight some parameters of overlap syndromes. And we know that there are a lot of combinations can occur. Rheumatoid arthritis with SLE, with Sjögren's syndrome, systemic sclerosis with rheumatoid arthritis and myositis, and vasculitis with IgG4-related diseases, and so on. And one of them are so frequent that got a designation, an own designation, such as lupus or scleromyositis. We know that the lupus patients sometimes overlap with rheumatoid arthritis, and erosive polyarthritis can occur, and this showed a correlation with the biomarkers as rheumatoid factor and ECPA antibodies, and not only this, but anti-CARP protein also, and correlation with the MRI findings. And this is an analysis, application of machine learning system analysis, which showed the evidence that the erosive polyarthritis with SLE, rheumatoid arthritis overlap can show a correlation between the ACPA and CARP protein. What we know about the scleroderma overlap? It's an evaluation involving more than 500 systemic sclerosis patients, and they were screened for concomitant CTD, and 6.4% of the patients were identified as having overlap syndrome. And this was rheumatoid arthritis, Sjögren's syndrome, and SLE overlap. And it was an evaluation for the survival of these different populations. And it shows that age-modified Rodnan score and the presence of concomitant Sjögren's syndrome were significantly associated with mortality. And overlap systemic sclerosis were more likely to receive corticosteroid and other immunosuppressive drugs and biologic. And you see here the survival rate, which shows the difference between the different overlapping groups. There is a special analysis from the Australian scleroderma cohort study where more than 1,000 patients were involved, and one part of the patients was systemic sclerosis, MCTD patients, one part systemic sclerosis, other overlap. And you can see the difference. There are more Asian race in the SSC MCTD overlap than in the other. They were younger age, limited form occurs equally, and the PAH was less common in SSC-IL overlap. And you see here the different antibody profile according the survival rate, and you see that the worse was correlated with RNA polymerase III antibody, and the best was together with the RMP antibody. So it's a therapeutic challenge for us to treat these patients because we have some drugs which can not be allowed for the treatment. For example, corticosteroids have to be cautious with systemic sclerosis. We don't know whether biological agents is efficient for one disease, really efficient in the other disease also. For example, TNF blockers may be used for RA, but it's not so good if the patient has RA-SLE overlap. So be careful. And of course, in summarizing, the overlap syndromes are common. Some of them can be considered as an independent entities. Prognosis and survival differ from the involved single disease alone. And based on risk assessment, we have to choose an optimal management for that patient. Of course, we are looking for other mechanism to treat the patient. And you see above here on the right above corner that there are processing differentiation between the different diseases. Maybe we have a different inflammatory, lymphoid, and interferon pathway. And all of our CTD patients can be involved in one of these features, and maybe this will be the driver for us to choose an optimal therapy. Finally, at the beginning of the dealing with the patient, sometimes we don't know what we are facing, but later on it's a colorful world, and our patients show different style and different problems for us. Thank you very much.